thank you so much to Tracy and to the organization for inviting me to speak. I hope that everyone will feel free to put any questions that they think of in the chat. So I'm going to be talking about a number of different things, but I'll start out with talking about diabetes and Wolfram, but then I do have some additional things to add after that. All right, let me be sure I can, okay, there we go. So as you know, I am part of a large group that is studying the natural history of Wolfram syndrome, based at Washington University in St. Louis, in Missouri. So this natural history study has been going on for quite a long time. It was started really at with the stimulus from families of people who had children with Wolfram syndrome or still have children with Wolfram syndrome. These parents found Dr. Barrett and Dr. Permit, who was here in St. Louis, and implored them to do something for their children. And so Dr. Permit, who was a endocrinologist in the Department of Medicine, had identified the gene that causes Wolfram syndrome. He wasn't really a clinical investigator, but he looked into what he could do. And the recommendation from people studying rare diseases was start a natural history study, because if you have the data of what the disease does over time, it makes it much easier to do intervention studies later on. So Dr. Permit got the ball rolling on this natural history study. We saw the first patients in 2010. Dr. Tamara Hershey became the principal investigator of the study. She developed the brilliant idea of putting it to our National Institutes of Health that if we study Wolfram syndrome, we'll be learning a lot about diseases that are much more common. So yes, Wolfram syndrome is very rare, but things that we learn about Wolfram syndrome may apply to things that are very common, like Alzheimer's. So Dr. Hershey organized a large group to work on this project, and I'll show you all their names at the end. So the idea behind the natural history study was to find features of Wolfram syndrome that we could follow how they progressed over time so that we could predict what would happen if we did not make an intervention. That way, if we did make an intervention, we could tell if we were changing that progression. So we intentionally selected people who had more early onset forms of Wolfram syndrome, with the idea that those people may progress fast enough that we could have shorter intervention studies. So if someone's disease progresses very, very slowly, then it may take many years to tell if an intervention is helping. Whereas a disease that progresses quickly, it's easier to tell if something is making a difference. So our criteria have evolved a bit over the years, but because at the beginning, it wasn't so easy to confirm by genetic testing. But at this point, all of our participants have Wolfram syndrome confirmed by genetic testing, and all less than 30 years old at the time of enrollment. Most of them also had diabetes mellitus starting prior to age 6, but not all. So we have collected data annually. We have had large clinics where people travel to St. Louis once a year. They've been so far all in July. And they stay for several days getting a number of assessments. So we collected data every year from 2010 to 2017. We missed 2018 because of our government was not funding our our budget. We were having a government shutdown, so we missed 2018, unfortunately. We met again in 2019, and then we all know what happened in 2020. So we did not meet in 2020 or 2021. So at each visit, each participant had the opportunity to have many different assessments. Some people did all the assessments, others only did ones that they were able to, but we did very detailed vision assessments, hearing. We have assessments of people's gait and balance, very detailed MRI studies. We measure C-peptide, which I'll explain more about in just a minute. We have assessments of how well people are able to taste things, how they can smell things, their cognitive function, and a number of neurologic function testing. So again, the goal of the study was to determine the rate of progression of the various features of Wolfram syndrome to establish a baseline for future safety and intervention studies. So our other goal from the start was to look for a biomarker. So a biomarker is a blood test or a urine test that will allow us to track progression of the disease. So most people would be familiar with the hemoglobin A1C test. So that is a way to test how your diabetes mellitus is doing. So we don't have a similar test for Wolfram syndrome. I can't draw a blood test and say, well, your Wolfram syndrome is getting worse or your Wolfram syndrome is getting better. But that would be awfully nice if we had such a thing, so that when you start a medication, such as one of the ones that Dr. Urano is studying, then we could draw this test and say, oh, your number went down, so that means your Wolfram syndrome is getting better. So that's one of our big goals that we are still working on. So I want to tell you a little bit about the participants in our study. Our first clinic back in 2010, we had only 10. We are up to 44. So we have 23 women and 18 men or boys. We have children and adults. The age at the very first visit to the clinic on average is 13 and a half, but a wide variation, plus or minus almost 6 years. Our youngest has been 4.8 years old, and our oldest at first visit, 27 years old. At their most recent visit, they're obviously getting a bit older. So average age at last visit, 18 and a half, but range of last visit, 4.8 up to 33.7. So we are continuing to enroll new patients who are some of them are coming in at those young ages. The participants that we have enrolled, the average age at which they were diagnosed with Wolfram syndrome is 11 years, but also a wide range there, all the way from 2.7 years up to 25.4 years. The age that those same participants were diagnosed with diabetes mellitus, average age was 5.8, but the range again is wide, 2.3 years up to 14. So some of our participants have come to many visits, others only one. We have 5 who have had less than 2 visits. We've had 9 who've had more than 6 visits, and everyone else is in between. We have enrolled 3 who had not yet been diagnosed or who have still not been diagnosed with diabetes as of their most recent clinic visit. 2 of those are girls aged 12 and 15 and 1 boy aged 16. So in tracking the progression of the diabetes mellitus, each year when the participant attends one of our clinics, they have what's called a mixed meal challenge test. So this involves their having blood work. They come over to the clinic before they eat breakfast, and they get blood work, including a glucose, a hemoglobin A1C, and a C-peptide. They then drink a meal substitute formula that's called Boost. So it's just got carbs, proteins, fats in the proportions that you would have in a meal. So they drink that, and they have blood work again after 30 minutes. So this is a way to tell how much the person's own pancreas can produce insulin when it has the stimulation of a meal. So on the day that these participants have the test, the ones who were taking insulin, they continue their insulin, but they did not take a dose to cover the boost. So the boost definitely makes their blood sugar go very, very high. And they're very tolerant of us letting their blood sugar get so high. So that's part of the reason we do the blood work after only 30 minutes. In a lot of research, you'll see that blood work done later than that. But asking them to maintain a blood sugar so high was really difficult. And so we did not do that. So at 30 minutes, they're able to take their insulin. And if they're still hungry, they can have their breakfast. This is not our most popular test. It's probably our most unpopular test, but the patients have been very kind to do this. Almost all of them have done this every year. So C-peptide that I was mentioning. So C-peptide is a part of the molecule that your body makes when it's producing insulin. So our pancreas produces a long protein called proinsulin when it's making insulin. So that proinsulin inside the beta cell curls up, and these two little bridges you see, those are called sulfide bonds. So they connect the two ends of the chain into two long sort of sticks. And then the pancreas cuts off this part of the loop. So this part of the loop, it's produced in exactly the same amounts as the insulin molecule, because it's part of the insulin molecule. And it is in fact also secreted by the pancreas along with the insulin. So whatever insulin comes out brings along some C-peptide. So we can use that C-peptide as a way of measuring how much insulin that person made themselves. The reason that is useful is most of these people are taking insulin. So if we just assay their insulin level, part of what we're going to be measuring is the insulin that they took from their shot or from their pump, and not the insulin they made themselves. So what we want to know is how much insulin they are still able to make. So we use the C-peptide. And this is a very commonly used method of determining how much insulin someone is making. So this is showing you the data that we've gathered from all of these studies. So each little point on this graph is one person having one of these tests. The points are connected if the test is from the same person. And what you see on this graph at the very bottom is how many years that person had had diabetes at the time they took the test. So this red dotted line is at 0. So points that are on the left side, that test was done before that person was diagnosed with diabetes, before they had diabetes. On the ones on the other side, on this side, the person already had diabetes. This side, that's called the y-axis, that is showing how high their C-peptide got. And so what you can see is that when someone either doesn't yet have diabetes or they have just recently developed diabetes, their C-peptide is higher. This is getting close to where, or this actually is in the range where someone who doesn't have diabetes would have a C-peptide level. But the longer the person had diabetes, the lower their C-peptide went. So the less insulin they were able to produce on their own. So we have tests all the way out to someone who's 30 years after they were diagnosed with diabetes. And you can see that after approximately 10 to 12 years, there's really not a very significant amount of C-peptide. When the level gets below about 0.5, that is really not a very significant amount of insulin. It's not enough insulin to really be doing anything for the patient's blood sugar. So The data is helpful though, and that is because if you'll notice, there's a pretty constant decline in this first 5 to 7 years. So it's predictable what someone's C-peptide will do. So predictability is what we need for these intervention trials. We need to know that if we don't do anything in terms of an intervention, the C-peptide is going to do this. Because if we do an intervention and the C-peptide drops much faster, then we'll know that that intervention made things worse. If we see that the C-peptide drops slower, then that will tell us, well, maybe that intervention is actually helping. So what that means is C-peptide can be a marker of progression of this feature of Wolfram syndrome. So what we see is the biggest decline in the C-peptide is in that first 2.5 years after diagnosis with diabetes. And notice that's after the diagnosis with diabetes, not after the diagnosis of Wolfram. So that's very important. The next thing is by 10 years after diagnosis, like I said, not much C-peptide is usually left. So this issue of needing to get those C-peptides in the first 2.5 years for optimal use of this as a marker of progression, we looked back to see, well, who in our study was diagnosed soon enough for that to be a good marker. So out of the 44 people in the study, 14 were diagnosed with Wolfram syndrome within that 2.5 years after they developed diabetes mellitus. So in those 14 people, they would have been in this range of rapid decline. Now, there's still a lot we don't know. So, for example, if we give someone an intervention that increases their production of C-peptide, do we reset this? Do we move them back to here? Or do we just slow this down, but we don't really back it up? We don't really know yet. Hopefully some of the studies that are underway are going to give us that information. But so far, this is the most information that we have on a significantly large number of people. So now clearly there's lots of features of Wolfram syndrome. And so we want to look for any markers that are helpful. So another marker that we have found that looks like it is going to be helpful for tracking progression is vision. So in our natural history study, we have data from 43 participants. Out of those, 38 have more than one visit where they got their vision checked. And we have an average of 6 years of follow-up. The range of years of follow-up is 2 to 10. So longer follow-up obviously is helpful, but any follow-up is good. Of the people who we have vision data on, the average age at their first visit was 13, average age at their most recent visit, 18. 42% men, the rest women or girls. Average age of diagnosis of optic atrophy in this group was 10.5 years. So what we have found is that visual acuity, which is how well you can see. So when you hear somebody say their vision is 20/20, that's a measure of visual acuity. So that visual acuity measurement decreases over time in Wolfram syndrome at a fairly constant rate in an individual. However, the rate of the decline varies by person. So some people decline faster, some people decline slower. There is a minority of people who have Wolfram syndrome who decline at an unusually fast rate. So we defined that as more than one line on the vision chart per year. So the vision chart I'm talking about is that Snellen chart that has the letters of different sizes. Sometimes they're E's for younger kids, they're different letters. But if you lose the ability to see a line in a year, then we pull you into that faster rate of decline. But since that rate of decline of vision is fairly constant in a person, that can be used as a marker of progression. It's a little more complicated than diabetes because everybody has their own rate of decline. So you may need to use an individual's previous rate of decline as their control rather than comparing them to the whole group. If you have that data, you may not have that data, in which case you may just need to use the average. So another thing that we have identified is changes in the MRI. So Dr. Hershey has published a tremendous amount of data on the MRI changes in Wolfram syndrome and in other disorders, including diabetes, type 1 diabetes. So, so she has been able to monitor changes in various parts of the brain. So she can actually measure the volume or how big each different part of the brain is to see if those parts of the brain change in size over time. And she has data in people who have no known health problems or people who have type 1 diabetes, so that she can tell the difference between changes that are caused by normal aging, changes that are caused by just diabetes mellitus, and changes that are associated with Wolfram syndrome. So what she has found is that the volume of certain parts of the brain, and particularly the brainstem and a sub part of the brainstem called the pons, decrease slowly over time in Wolfram syndrome and at a steady rate. So the change is slow, but it's very steady. So that makes it a good marker. The change is slow enough that you may need 2 to 3 years of following the rate of change to be able to tell if there's been a change in the rate of decrease when you try an intervention. So you may need to watch what happens with that intervention for a couple of years before you can say this intervention is changing the rate of decline. The other downside to the MRI is obviously it's a very expensive test. It's time consuming. The participant has to be willing to lie in the MRI machine for a long period of time, which is, it's not painful, but it's claustrophobic and it's not the most fun thing to do. So, so markers of progression that we have in hand are the C-peptide, the visual acuity, and these MRI changes. And as you heard from Dr. Urano, these things are being used in studies to try to tell if interventions are making a difference. So we're still looking for that perfect blood test or urine test. We do have a new one that's on the horizon. So this is a protein called Neurofilament Light chain. So this is one of lots and lots of proteins that we have. It's one that is important in our neurons or our nerve cells. So this is a drawing of a nerve cell that I took from a paper actually on Alzheimer's disease that is describing this neurofilament light chain and proposing to use it as a marker of progression for Alzheimer's disease. So this is being considered as a marker of progression in a number of diseases that cause changes to the nervous system over time. So the drawing here is showing you a nerve cell. So what nerve cells look like is they have the body of the cell, which is the main part where the nucleus and all the control center is. And then nerve cells have these long extensions called axons. And this cartoon greatly minimizes how long the axons really are. So these axons may reach all the way from a nerve cell that's up in our brain, all the way down our back to a connection down in our spine somewhere, or they may reach from a nerve cell that's in our spinal cord all the way down our arm or our leg. So it may be many inches or feet long. And so this, you know, a cell is sort of a bag of jelly. So the cell needs to have a little bit of a skeleton, just like our body has a skeleton that sort of keep it in the right shape. So neurofilament light chain is one of those parts of the cell's skeleton. So they're proteins that form little sticks, and the sticks get together into little bundles and form tubes that the cell uses to maintain its shape, to maintain this long, skinny shape that it needs. So as the cell is alive, or it's changing or growing, or possibly as it's deteriorating, it will sometimes lose some of its proteins, or it normally loses some of its proteins. The protein gets old, or for whatever reason, the protein comes out of the cell. So that protein then shows up in our blood. So serum is the clear part of blood that doesn't have cells. So it shows up in our serum. It can show up in our CSF. So CSF is the fluid that surrounds our brain. If you have a lumbar puncture, that clear fluid that comes out, that's CSF. ECF is extracellular fluid. So this is the fluid that just oozes out if you have a cut. It's the clear stuff it's not blood, but it's the fluid that our cells live in. So this neurofilament light chain protein can be found in all of these places. Vitreous is the fluid inside our eye, so it can also be found there. So if you have a sample of one of these fluids, you can measure how much of this neurofilament light chain is in it. And the idea is that perhaps if a nerve cell is sick or it's having trouble, perhaps it would lose more of this neurofilament light chain so that you could find more of that protein in these fluids. So, as I said, this has been shown to be the case in Alzheimer's disease. So people who have Alzheimer's disease have more of this neurofilament light chain in these fluids. So Dr. Hershey and Dr. Urano and the group decided to see, well, what about in Wolfram syndrome? So as this natural history study has progressed, each of the participants who was having that boost test that I told you about, the mixed meal study, when they had their blood drawn, we saved some samples of the blood, and we also saved some samples of their urine. They've been safely tucked away in a freezer in Dr. Urano's lab, and so we can pull them out and measure things after the fact. So we pulled out 65 samples from 2014, 16, and 17. Of those samples, 27 of the participants who had donated the samples, we had more than one sample from them over time. So out of these samples, 27 were people who had, we drew 2 different time points so that we could look and see if there was change over time. We also have been collecting samples from parents and siblings of our natural history participants. So the parents and siblings do not have Wolfram syndrome. They may be carriers, but they do not have Wolfram syndrome. So they are our control samples. All the samples are drawn fasting. So these are from that first time point in the mixed meal study. So this paper, if you're interested, has come out just this year. Sarah Eisenstein is the first author of the paper, and Dr. Hershey is the senior author. So what we found in these samples was that the neurofilament light, which is called NFL for short, is found in blood at higher level in people who have Wolfram syndrome than in people who don't have Wolfram syndrome. So this y-axis here, the upright axis, is showing you the concentration of the NFL. It's the log 10 of it, which just makes it easier to put on the graph. And then these dots are the first time point of the people who have Wolfram syndrome. This is from the second time point, and this is the controls. So you can see that the average level of NFL in the blood in the people who have Wolfram syndrome is higher than the average level of the people who do not have Wolfram syndrome. You also see that there's some variation. So some of the people with Wolfram syndrome, their NFL level is in the range where the people who don't have Wolfram syndrome lie. But their average is higher. So perhaps a good tracking means. We don't see a big change over time. So what that means is not entirely clear. It may mean that the person who had Wolfram syndrome, there hadn't been much change in what their nerve cells were doing. It may mean something else. We don't really know yet. This is really the first look at this information. So we also wanted to see if those NFL levels tracked with any of the features of Wolfram syndrome, to see if, are they predicting when someone's visual acuity or someone's brain volume size is changing. So these 6 graphs are showing you that information. So this panel A and panel D are showing you visual acuity on the upright y-axis on both of them, and then the NFL level on the bottom axis, on the horizontal axis. The top one is time point 1, the bottom one is time point 2. So you can see there's definitely not a perfect little lineup of soldiers going up in a row, but there is a general increase or there's a generally higher NFL level in patients whose visual acuity is worse. So higher on this graph is worse visual acuity, and higher on this graph is higher NFL level. So there's a tendency for those who have worse visual acuity to have higher NFL levels. Now, this is time point 1. This is time point 2. I think that is incorrect. This is time point 1. This is time point 2. So no, I take that back. These are NFL levels only at time point 1, but this is the visual acuity at the different time points. So it's what you see is similar in both. So possibly this is encouraging. We don't have a lot of points. It's not unusual for scientific data to show sort of a scatter like this, but it's encouraging that it's at least not going in the wrong direction if we're going to use this as a predictor. This figure is showing you color vision, and in this figure, a higher number for color vision means better color vision. So you can see more colors if you have a higher number. So as your the people who have lower color vision have higher NFL levels. So possibly a predictor there. Again, this data is very what we call noisy. So it's kind of, it's not a very strict line. There's data that's all over the place, but there's a tendency to go in this direction. The same thing holds true for thalamic volume. So this is the size of one of the parts of the brain stem. So as the person had a smaller one of their thalamus, they also had higher plasma NFL levels. Upsit is a measurement of how well you can identify smells. So the higher your upsit number, the more smells you can identify. And the lower your number, the fewer smells you can identify. So the people who could identify fewer smells had higher NFL levels on average. This last figure F is another one of the measurements of brain size. And again, those who have smaller brain volumes had higher NFL levels. So it's important to realize that this does not tell us that having a higher NFL level helps your color vision or having a lower NFL level hurts your color vision. It's just telling us that having a higher NFL level correlates with having lower vision or lower color vision. So this is not telling us that NFL is a possible treatment for Wolfram syndrome. So giving someone more NFL is not, this doesn't tell us that giving someone more NFL may make their vision or whatever improve. It just means that it may be a sign that someone has more trouble with those areas. So there's other considerations when you're designing intervention studies, and some of those considerations our natural history data can provide some information for. So probably the most important consideration is that an intervention that addresses the biggest concerns of the person with the syndrome is an important intervention. If you're just addressing something that the person doesn't really bother them, then it's less helpful. That doesn't mean you don't want it, but it may be less helpful than something that's addressing what's really important. So, so this is a study that was headed up by the occupational therapists who are participating in our natural history clinic. So this is looking at what features of Wolfram syndrome affect the person's ability to participate in activities that they want to do. So the participants were not exclusively those in the natural history study. This was a questionnaire study that was extended to the International Wolfram Registry. So 45 participants took the survey. 20 of them were children, 25 adults, and then 36 participants who do not have Wolfram syndrome completed a portion of the questionnaire, the parts that didn't specifically relate to Wolfram. And then the participants that we had symptom data for, those were compared with the data that was collected from the survey. And this was not a study that I'm telling you this data, but it's not my data. So what the study found, this figure is showing the symptoms that people reported had the most impact on their ability to participate in activities that they wanted to do. So the symptom impact score is shown here, and a higher number means that a particular symptom had more impact on their ability to do what they wanted to do. The black bars are the answers from the children, and the white bars are the answers from the adults. So if you look at the bars, what you see is that the symptom that was reported by most people as affecting their ability to participate in things they wanted to do was vision loss. So 18 of the children and 24 of the adults reported that was a problem for them. The next most for the adults was walking and balance. And then bowel and bladder problems was a big problem for both. Hearing loss was a problem more prominent for the adults. And then diabetes was a problem for both about equally. But the problems that have to do with your nervous system, the vision, the walking and balance, and the bowel and bladder were very prominent. So this is more of the data showing what sort of domains of activities were affected by the features of Wolfram syndrome. So, so the children are here in the top section, the adults are in the lower section, and then WFS, this column is people who have Wolfram syndrome. This is the people who do not in the comparison column. So you see that for both adults and children, things listed as obligatory chores are the things that are most often affected by Wolfram syndrome. But all different activities you will see are more of a problem for people who have Wolfram syndrome than people who don't. So if your number over here is lower, that means that you had less participation than people in the comparison group. So the most frequently mentioned items that Wolfram syndrome affected or prevented people from doing for children was bicycling, skating, skateboarding, and team sports. For adults, driving, relationships, meeting people, and exercising. So these are all pretty basic things that people would like to enjoy. So one thing that came out of this information that we should consider strongly when we are people like me who are caring for people with Wolfram syndrome, also for developing studies, of the participants in this particular survey, only 22% of those people had ever been provided with occupational therapy. So occupational therapy is directed at helping people more successfully participate in activities of daily living or activities that they want to do. So this is an opportunity for improvement on the part of people like me, the caregivers. This should be a much higher number. Lots more people with Wolfram should be provided with the opportunity to meet with occupational therapy. And secondly, while diabetes it's very straightforward to track the progression of diabetes. You can do this half-an-hour test, you can measure C-peptide, but the neurological concerns are generally more important features of Wolfram syndrome to the person who's affected by Wolfram syndrome. So it's terrific if we can make the diabetes better, but it would be even more terrific if we could make the neurological concerns get better. So future for the natural history study. So obviously COVID slowed down data collection completely shut it down for 2020 and 2021. This year, we had the same problem that you had in planning, which was at the time we needed to start planning our clinic was the winter and we were having a horrible surge. So what we're doing is mini clinics. We're bringing in a few people at a time and evaluating the best path forward for those people. Lots of people to thank Dr. Hershey and her lab for all the studies I talked about. These people that are listed who were particularly involved with the C-peptide vision and NFL studies, a large group of people who are involved in the whole study as a group, and then of course all the current and the former participants in the TREC study, which is what we call our study, and their families. So thank you. I hope I left enough time for questions. I'll stop.
Lovely, thank you, Bess. I think that was really informative and I think everyone will agree. So we have a question that's coming in the Q&A and I do have one as well in the that's coming prior to today. So sorry, excuse me. So the one that I've had sent in before today's session: my 20-year-old WS son was told by his endocrinologist that he is very resistant to insulin and he takes large doses of Nova Rapid, sort of 30 to 35 units with every meal, and 28 units of Mellitus twice daily. Is it something to worry about?
So that's a really good question. So there are lots of things that affect how much insulin we need. So the needing more insulin, we sometimes refer to as being insulin resistant or resistant to insulin. So someone's insulin resistance varies a lot based on their genetics. So people who have type 2 diabetes, for example, are very resistant to insulin. So someone who has type 2 diabetes in their family may just be genetically resistant to insulin, and so they need more insulin to do the same job. Things like exercise and a healthy diet make us more sensitive to insulin, but can't necessarily, in most cases, overcome genetics. So if you're just genetically very, very resistant, no matter how healthy you eat or how much you exercise, you may still just need a lot of insulin. It does not necessarily mean that your diabetes is worse. So, I wouldn't worry about that. And taking more insulin in and of itself is not it's not bad for you if you need that insulin to control your blood sugar.
Lovely.
And Dr. Barrett may want to chime in if you have any. He's also very experienced taking care of Wolfram with diabetes, but
Tim, do you have anything to add to that question?
No, I think Dr. Best-Marshall covered it very well. I think really it is quite common to be insulin resistant. We do see it in Wolfram type diabetes as well as common diabetes as well, and it's best to get advice from the local doctor about the best way to treat that. And it's usually a combination of different medical treatments, but also lifestyle things to do to try and help make the body more sensitive to insulin as well.
Lovely, thank you. We've had a question come in, so everyone that's on, please don't forget to put in any questions that you might have. How can we be volunteers of these tests from European countries?
So very good question. So for the studies that are taking place in St. Louis, if you have access to the internet, if you look on the websites for Dr. Hershey and Dr. Urano, there is information about getting involved with the studies. There is a registry that you can fill out information on, and that will get you into the database. And then we review that data in St. Louis, and patients who are eligible for one study or another will be contacted. Right now, the natural history study is not currently able to bring anyone from overseas. We do have participants from overseas, but we haven't been able to bring them in since COVID started. We hope that will change because we do have quite a few. But right this minute, we don't. However, if you are interested in any studies, so some of these, for example, the one was just a survey study you could do from your local place. So I would say join those registries. I think there's also the registry in the UK that will get you that information. There's also contact information on those websites, and you're welcome to shoot us an email.
Lovely, thank you. I think we include some of the contact information in Dr. Urano's updates, which we do put onto the WSUK website and in the quarterly newsletter. But if you're interested, then please contact me as well, and I can always get the information to you. Okay, we have another one. What do you think about liraglutide for diabetes treatment?
So, we know a reasonably large amount of liraglutide information for people who have type 1 and type 2 diabetes. For people who have Wolfram syndrome, we're getting information. So one of the things that liraglutide does is it causes your stomach to empty more slowly, and it may stimulate your own pancreas to produce a little more insulin than it normally does. So it is what we are seeing in many people with Wolfram syndrome who are taking the liraglutide is that their insulin dose goes down. That we don't know if that means that their body is producing more insulin by itself, because that study unfortunately started at exactly the same time that our COVID shutdown started. So we are only just starting to collect any data at all on those participants we have a small study of liraglutide, but we've only just started collecting data. So I can't tell you whether it is actually causing the diabetes mellitus itself to get better, or if it's only causing you to need a little less insulin. The other information we don't have anything on yet is whether it may be affecting any of the neurologic features of Wolfram syndrome. But the good news is we are now beginning to collect that data. So hopefully over the next months or short number of years, we'll be able to give a better answer to that question.
Future presentation to come.
Yes.
Lovely. At the moment, we don't have any more questions. So I think that will possibly be it. So thank you very much, Beth, for giving up your time and giving us a fantastic presentation. Once again, this presentation will be added onto the website, the WSUK website. So if you want to rewatch it, you can do. If you have any questions that you think of once we've finished, or once you've rewatched the presentation, then again, please email them to me at admin@wolframsyndrome.co.uk, and I can forward them on to Dr. Marshall, and she can send me the replies, and I'll send those on to each person that has asked the question. Oh, we've had one more pop in. They did this earlier as well. Will the WSU liraglutide study have similar outcomes and measures to the Estonian liraglutide study in the WFS1 rats? Meaning, will it look at slowing the progression of ONA in humans?
So we are, the way the study is designed is patients who were already in the natural history study were enrolled in the liraglutide study. And so all of the measures that we've been collecting all along, those patients will still get collected, and we'll be looking at each one of those features to see whether there's a change in that rate of decline or increase, or whatever's been, however that person has been changing in the past. We're going to look to see if that change is different. So so it's going to look at all the different features that we've already been studying.
Lovely.
The animal data is so helpful, and obviously doesn't get shut down by COVID quite as easily. So hopefully we'll move along a bit faster.
Lovely. Thank you so much. And I look forward to seeing you at some point in the future.
Thank you.
Lovely.
You too.
Thank you. Take care.